This video will focus on the structure and function of the kidneys, including the components of the nephron and the biochemical aspects of renal disorders. The nephron is the functional unit of the kidney. It consists of the renal corpuscle and the renal tubule. The renal tubule includes the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. The tubular fluid then empties into collecting ducts. Kidney functions include excreting metabolic end products, such as urea and creatinine. They also maintain homeostasis by controlling solute and water balance, as well as acid-base balance. Kidney function depends on an adequate blood supply, which is about 20% of the cardiac output. It also relies on normal hormone secretion and feedback, and the integrity of the glomeruli and tubular cells. The kidneys also have important endocrine functions. They produce 1,25-dihydroxyvitamin D, the active metabolite of vitamin D, and erythropoietin, which stimulates red blood cell production. Glomerular function involves producing ultrafiltrate. This depends on blood flow and the pressure difference between the hydrostatic pressure gradient and the plasma effective colloid osmotic pressure across the membranes. The colloid osmotic effect is relatively weak compared to the hydrostatic gradient. However, it assists in the reabsorption of fluid from the proximal renal tubules. In tubular function, changes in the filtration rate modify the total amount of water and solute filtered, but not the filtrate's composition. Tubular cells use active transport, often selectively, against physicochemical gradients. Transport of charged ions can create an electrochemical gradient that limits further transport. This is minimized by two processes: isosmotic transport and ion exchange. Isosmotic transport, mainly in the proximal tubules, reclaims filtered essential constituents. Active transport of one ion causes passive movement of an oppositely charged ion in the same direction. Ion exchange, primarily in the distal nephrons, adjusts fine balance after bulk reabsorption. In the proximal tubule, almost all potassium and over 70% of filtered sodium are actively reabsorbed. Free ionized calcium and magnesium are also reabsorbed. Bicarbonate is almost completely recovered following the exchange of sodium and hydrogen ions. Specific active transport mechanisms ensure the near-complete reabsorption of glucose, urate, and amino acids. Almost all reusable nutrients and electrolytes are reclaimed in the proximal tubules, while most filtered metabolic waste remains in the luminal fluid. Renal dysfunction affects all parts of the nephrons to some degree. The impact on plasma and urine depends on the extent of glomerular versus tubular dysfunction and the number of nephrons involved. With a reduced glomerular filtration rate and normal tubular function, the plasma concentrations of urea and creatinine will rise. Phosphate and urate also increase because less is filtered, and reabsorption capacity is reduced. When GFR is low, a large amount of filtered sodium is reabsorbed by isosmotic mechanisms. This results in reduced hydrogen ion secretion, lowering plasma bicarbonate, and reduced potassium secretion, leading to potassium retention. If a low GFR is coupled with low renal blood flow, systemic aldosterone secretion is maximal, leading to near-complete sodium reabsorption. Increased ADH secretion causes water to be reabsorbed in excess, reducing urine volume and increasing osmolality. The findings in affected nephrons with reduced GFR and normal tubular function include high plasma urea and creatinine, metabolic acidosis, hyperkalemia, and hyperuricemia. Urine volume is reduced, a low sodium concentration may be present if blood flow is low, and high osmolality may occur if ADH is stimulated. Reduced tubular function with normal GFR impairs the adjustment of urine composition and volume. Impaired reabsorption reduces isosmotic water uptake, leading to a large volume of inappropriately dilute urine. When tubular function is reduced, the tubules cannot secrete hydrogen ions, leading to impaired bicarbonate reabsorption and urine acidification. The response to aldosterone is also impaired, causing an inappropriately high sodium concentration in the urine. Findings with reduced tubular function include normal plasma urea and creatinine. Low bicarbonate and pH indicate acidosis, and hypokalemia may be present. Hypophosphatemia, hypomagnesemia, and hypouricemia may occur due to proximal tubular failure. Urine findings with reduced tubular function include increased volume and inappropriately high pH. Proximal tubular failure causes aminoaciduria, phosphaturia, and glycosuria. Distal failure results in high sodium concentration and low osmolality despite appropriate hormonal stimulation. Plasma concentrations of urea and creatinine mainly reflect glomerular function, while urinary concentrations largely depend on tubular function. Tubular impairment makes the concentrations in plasma and urine closer. Plasma sodium concentration is not primarily affected by renal disease. Since 99% of filtered water is normally reabsorbed, even minor tubular reabsorption impairment can cause polyuria or increased urine volume. Retention of potassium, phosphate, and urate depends on the balance between glomerular retention and proximal tubular reabsorption capacity. Metabolic acidosis, indicated by low plasma bicarbonate, can worsen hyperkalemia. Acute kidney injury, or AKI, is also known as acute renal failure. Oliguria, defined as less than 400 milliliters per day urine output, often indicates a low GFR. AKI can be classified as pre-renal, intrinsic renal, or post-renal. Pre-renal AKI, or renal circulatory insufficiency, is caused by factors that reduce the hydrostatic pressure gradient, often low intracapillary pressure. Causes include intravascular depletion, reduced intake, or reduced pressure due to vascular dilatation from shock, myocardial infarction, or cardiac failure. Acute oliguria due to intrinsic renal damage can result from prolonged renal circulatory insufficiency, acute glomerulonephritis, septicemia, or ingestion of various poisons or drugs. Myoglobinuria and Bence-Jones proteinuria are also potential causes. Acute oliguria from renal outflow obstruction or post-renal failure can be due to intrarenal obstruction by materials like hemoglobin, myoglobin, or calculi. Extrarenal obstruction may be caused by calculi, neoplasms, urethral strictures, or prostatic hypertrophy. Investigating AKI involves a careful clinical history, monitoring urine output, plasma urea, creatinine, electrolytes, and acid-base status. Hyperkalemia, hypermagnesemia, hyperphosphatemia, hyperuricemia, and metabolic acidosis can occur in the oliguric phase. Urine microscopy may show granular casts, suggesting acute tubular necrosis. The urinary to plasma urea ratio, if greater than 10:1, suggests pre-renal issues. The fractional excretion of sodium, or FeNA percent, is a useful diagnostic tool, and FeNA percent of less than 1% is typical of pre-renal failure. Chronic kidney disease, or CKD, is reduced eGFR, proteinuria, or renal structural abnormalities lasting over 90 days. It often results from diabetes, hypertension, glomerulonephritis, or other conditions. The functional adaptive effects of CKD are categorized as diminished renal reserve, renal insufficiency, and end-stage uremia. CKD may pass through an initial polyuric phase, followed by oliguria or anuria, requiring dialysis or transplantation. In the polyuric phase, falling urea excretion and rising plasma concentration cause osmotic diuresis in functioning nephrons. Tubular dysfunction contributes to polyuria, and metabolic acidosis is usually present. During the oliguric phase, nephron destruction leads to reduced glomerular filtration and decreased urine output. Oliguria causes a steep rise in plasma urea, creatinine, and potassium concentrations, and the metabolic acidosis worsens. In CKD, abnormalities include uremia, hyperkalemia, and metabolic acidosis. Plasma phosphate rises and calcium falls. Secondary hyperparathyroidism occurs early, and plasma urate concentrations rise. Hypermagnesemia is also a feature. Other features of CKD include normochromic, normocytic anemia due to erythropoietin deficiency. Hypertriglyceridemia, low HDL-C, and abnormal endocrine function may also be present. Increasing proteinuria is the best predictor of disease progression. Glomerular function tests include measuring plasma concentrations of urea and creatinine, which accumulate as function deteriorates. Clearance tests assess the glomerular filtration rate. To calculate GFR, radiochromium-labeled EDTA is considered the gold standard exogenous compound. Creatinine is a commonly used endogenous compound because its production is relatively constant. Plasma creatinine may not exceed the reference range until GFR is reduced by about 60%. Creatinine clearance is more sensitive for early dysfunction, but cannot distinguish between different causes of reduced GFR. Cystatin C is another endogenous substance useful as a GFR marker. Its blood concentrations are independent of patient age and sex, and it is neither secreted nor reabsorbed by the renal tubules. Renal tubular function tests are divided into those that identify proximal tubular dysfunction and those that identify distal tubular dysfunction. Diagnosis of proximal tubular dysfunction includes urine analysis, which may show increased volume, inappropriate pH, phosphaturia, glycosuria, uricosuriia, and generalized aminoaciduria. Distal tubular function tests reveal that impaired function primarily affects urine acidification, resulting in a failure to excrete hydrogen ions. There is also an impaired response to aldosterone, with high sodium in the urine. In the diagnosis of renal dysfunction, plasma analysis may show hyperchloremic acidosis, hypokalemia, and low pH. Urine findings include increased volume, inappropriately high pH, and high sodium and low urea concentrations, even if ADH is stimulated.